Okay, one more talk before our reception starts. This is the lower extremity extracorporeal distal revascularization in a swine model of prolonged extremity ischemia, presented by Joseph Edwards with the group from Uniformed Services, University of the Health Sciences in Bethesda, and the Mayo Clinic, and the senior author is Jonathan Morrison.
But I don't think that's Joseph.
Yeah, so I am not Joseph Edwards, but
I
I'll
didn't
be
even
giving
see
the
who was
talk.
next to
Yeah,
me.
no, it's fine. Okay, my name is Rebecca Truffles, and I am a third-year medical student, and I am presenting for Joseph Edwards today. And I'll be talking about the lower extremity extracorporeal distal revascularization technique. We have no disclosures. Acute limb ischemia, as we know, is a time-dependent emergency that requires prompt revascularization. This can occur in acute settings or chronic settings. We'll be focusing more on the acute setting today. Long ischemic times are associated with greater ischemic burden and poor functional outcomes, if not amputation. Temporary intravascular shunts can be used to reduce warm ischemic time. However, they do require going to an operating room, which within itself lengthens the ischemic time, and it requires a skilled surgeon to expose the arterial system and place the shunt. There are other documented techniques of ischemic limb reperfusion that build upon shunts. One is our group recently published on the lower extremity stage revascularization technique for acute popliteal injury. This is an exo shunt that cannulates the common femoral artery on the contralateral side and then the posterior tibial artery on the ipsilateral injured side, allowing for passive perfusion of the injured extremity. However, in our early clinical experience, we found that there was not sufficient central pressure to perfuse that limb. There are other techniques that look at more of an active flow, such as extracorporeal membrane oxygenation for acute limb ischemia, and then other endovascular techniques using the contralateral side. However, these are limited by cost, accessibility, as we discussed, technical difficulty, and passive flow. So today I'll be discussing lower extremity extracorporeal distal revascularization, also known as LEEDR. This is a technique where the tibial vessel is cannulated and perfused from the contralateral non-ischemic extremity using tubing and pump system. The aim of this pilot study was to evaluate this technique in a swine model of prolonged extremity ischemia. The initial instrumentation was standard using male swine weighing between 40 and 50 kilograms. They were placed under general anesthesia, and arterial and venous access was obtained for pressure monitoring and fluid and medication administration. Here on the bottom left, you can see that we used an off-shelf Silk Roads en route device and modified it for ischemic limb perfusion. Using the inflow sheath, we cannulated the right femoral artery and reserved this as the donor artery for our inflow. The outflow sheath was placed in the posterior tibial artery, and this was for our outflow recipient artery. Here is a left lower extremity and dissecting out the posterior tibial artery, and the en route outflow catheter was inserted and secured. Clip connectors and tubing were placed on the sheaths and placed into a roller pump. So here you can see a cartoon illustration of the LEEDR setup and our experimental model. To make an ischemic model, we dissected out the iliac arteries and the iliac vein. An iliac vein flow probe was placed so we could measure venous outflow. The iliac arteries were clamped to induce ischemia. So for the experiment, we had two groups. We had the LEEDR group, which, as discussed, we had the iliac artery, which is clamped for 1 hour. While the iliac arteries were still clamped, the roller pump was turned on, the LEEDR device was turned on at 150 milliliters per minute for 5 hours, with a total prolonged ischemic time of 6 hours. This allowed for perfusion of the distal ischemic limb using the contralateral side. After those 6 hours were done, the pump was turned off, the iliac arteries were unclamped, and 3 hours of reperfusion. In the control group, the left iliac artery was clamped, and 6 hours of prolonged ischemia was induced in these animals with no intervention. The iliac arteries were then unclamped, and 3 hours of reperfusion took place. Before any of this happened, baseline data was acquired, and the variables that were collected throughout the study included mean arterial pressure, iliac vein flow, compartment pressure, and laboratory values such as arterial blood gas, lactate, and potassium. Here is a full timeline of the experiment for a LEEDR animal. And during the 3 hours of reperfusion, the primary outcome was the development of compartment syndrome during this time. So all the way on the left, you can see an angiogram of the site of occlusion. You can appreciate that there is no distal blood flow. And then once the pump was turned on, you can see that we start to have retrograde flow from LEEDR. We confirmed that the limb was being perfused by measuring iliac vein outflow. The lines are a little bit messed up, but you can see on the right that the y-axis is flow, and then the x-axis is the time. And it's a little bit hard to see on here, but the blue lines are LEEDR on the top, and after the pump was turned on, it returned close to baseline and stayed consistent, whereas the control dropped dramatically, and then once we unclamped the arteries, then it went up. Compartment syndrome, our primary outcome. So compared to the LEEDR animals, the control animals had significantly higher compartment pressure. Yeah, the lines are a little bit messed up. You can see that the LEEDR animals on the bottom stayed consistent even during reperfusion period whenever the iliac arteries were unclamped, and the control spiked once the iliac arteries were unclamped. And along with this, the peak compartment pressure of the control group was significantly higher than the LEEDR animals. Compartment syndrome was calculated using diastolic blood pressure minus compartment pressure, and it was anything less than 30 millimeters of mercury was defined as compartment syndrome. Our control animals had significantly more compartment syndrome, with 3 out of 5 animals, 60%, developed compartment syndrome during that reperfusion period versus 0% in our LEEDR animals. In conclusion, the system was ultimately able to mitigate 5 hours of ischemia and sustain the extremity. The system is also able to be placed in the emergency department, unlike the shunt, and allows a more rapid return of blood flow. Using a large animal model, which has its inherent limitations, specifically for this was the difference in lower extremity anatomy. However, the physiology was rather similar. With this, our results are a compelling demonstration of the feasibility and efficacy of the LEEDR technique as a bridge to the definitive revascularization. Thank you, and I'll take some questions.
Hi, Dawn Coleman at Duke. Thanks for this work. It's really important. And I think what I'd like you to talk about a little bit is its applicability as you translate this forward to civilian and military settings for trauma. And especially as we think about future conflicts and prolonged evacuation times, this is really important. So I was hoping that you could speak a little bit towards your next steps and where you think this is going, its applicability to military and civilian settings, really with an emphasis on the former. And my last question is, you really emphasize how with kind of quick initiation of this adjunct following trauma, you're able to avoid fasciotomies perhaps, but I think in many settings where this might be indicated, you might want to still consider being proactive with your approach to fasciotomy because of the explosive nature, for example, of wounds and other reasons for compartment syndrome. So beautiful presentation, really well done. I know you're a medical student. I love that. Congratulations. And I look forward to seeing where this goes next.
Okay, yeah, thank you. Those are good questions. We have a few next steps, and the first one that we're going to be looking at the Mayo Clinic is looking at this in a prolonged time, so leaving this system in place for a long time, and I think that is very applicable to a military setting if you're transporting and seeing how this does over a long period of time, and it's also applicable to more of a chronic setting if someone has severe PAD that's refractory to revascularization and using that as a way to produce more collateralization. So there's multiple ways that we're going with this to see how that works in a longer setting. And then we're also looking at the device itself to see how we can transport that device.
Amazing stuff, and obviously has ramifications for trauma, but also for ECMO and Impella and other support devices with limb complications. Your take on if the roller pump is a necessary piece, right? I think a lot of us put an A-line in and put a distal perfusion catheter in many of those patients and hook them up together, and as you said, you're always relying on that central pressure. Has your group done any animal modeling with and without the roller pump as we think about how to make this easily available for everyone at the bedside, like you said?
Yeah, thank you. Before we even did this study, we did a preliminary model using passive flow, 50 milliliters per minute, 100 milliliters per minute, and then 150. And we were looking at the venous outflow during that time. And with the passive and 50 and then 100, there was minimal return of that venous outflow, so we were not really getting that perfusion. Once we hit 150, we were getting near return to baseline, maybe 70%, 75% or higher of venous outflow, so we chose that, and I think that does show that the pump is beneficial.
Yeah, just Johnny Morrison, this has come from my lab. Yeah, the world of blood pumping is kind of more complicated than you can imagine, in that our plan is to progress this work using a miniaturized centrifugal pump, and there's a pump that's occupying the kind of 100 mils per minute to 1 litre a minute kind of space, which isn't common, in that most centrifugal pumps are kind of the LVAD kind of flavour, which are, you know, looking at higher flow rates. So yeah, we've kind of done a dose response curve in terms of a roller pump with venous flow, but now we have a kind of centrifugal pump that should be able to do the job. So that's kind of in evolution.
Fantastic.
Kind of a related question. So since you have this pump, are you able to use smaller size sheets so that maybe these patients don't have to be heparinized?
Absolutely. And we kind of used the on-route system with kind of hot glue and scissors and putting things together just as a kind of proof of concept. Absolutely. The 8 French is too big, and I think, you know, the 5 French glide sheath slender that, you know, we use for radial work and that sort of thing would be ideal in the PT position. The problem is that 3-way connector that you have on the sidearm that really constricts your flow, and I think risks introducing hemolysis and all kinds of other kind of rheological things that you don't want. So what we liked about the Silk Road system was the connector system. So in their setting, so you can get flow reversal. Ultimately, we wish to kind of progress that work using a smaller sheath size. The other thing is you could do it with those commercial sheath sizes if you were to use an allosteric hemoglobin modifier where you increase your oxygen offloading. So there's other ways to kind of slice this to increase oxygen delivery. So yeah, there's a number of avenues that we are exploring.
Okay, that concludes our session. I was amazed by the science in today's session. It's fantastic.